Morgan, Professor. I'm just finding a location. I'll turn my camera on in a moment.
No worries. Jim, shall we start? Oh, quite a few people just started joining. So hello, everyone who has already joined us. Thank you very much for tuning in this Monday evening. My name is Yiwang, and I'm going to be the host of this session. Together with me are Jim, who's now the BSIRT president, and Sarah, who's a trainee at Leeds, and Indra, the founder of the IRJ. This is the sixth session of this year's new initiative, joint force of BSIRT and IRJ of the Virtual Journal Clubs, which will just hopefully spark some good discussion around the latest and hottest topics in intervention radiology. So today we're going to talk about the role of splenic artery embolisation in the setting of trauma. And I will do a very brief discussion on the topic itself and present a paper, and we'll hand the floor back to the panelists who are present here. We have Mr. Morgan Monagle, one of the trauma and vascular surgeons who work in both London and Ireland. We've got Professor Hamady, one of the IR consultants at Imperial College, and Dr. Kashef, another interventional radiologist based at Imperial and trauma intervention lead. Welcome. For the audience, you're welcome to submit the questions to the chat, and then we will keep that space monitored, and we'll send out a feedback towards the end of the session for you to help us improve the series as well. I'm just going to share my screen now. Is it presenting okay? Okay. So I'm one of the clinical radiology specialty trainees. I'm also based at Imperial College Healthcare NHS Trust. Just a little bit background on the trauma service in London. We've got 4 kind of geographic regions, and St. Mary's Hospital of Imperial is, as you can see, the red dots and square covering northwest London. Here's the image that people want to show you. It's a Paddington in a beautiful day, but sometimes it can get really busy trauma-wise. Splenic injury, if it's suspected, particularly in a polytrauma patient, on the left, you can see a very busy flowchart in terms of how these patients are managed. To simplify this, if the patient is hemodynamically unstable, the trauma team will trigger, sometimes using a fast scan, sometimes using CT to triage the degree of injury, I suppose. But if it's really patient is really unstable, sometimes they proceed straight to emergency laparotomy. I suppose we can talk a bit about that in the discussion session. Whereas for hemodynamically stable patients, we have more of a room to find out what exactly is going on and to what degree of injury that needs to be dealt with. With a lower degree one, sometimes it's non-operative management. That would include observation and or embolization. For slightly high grade, it may proceed to intervention, it may proceed to surgery. And the grading system really helps us. It's displayed on the right, so grade 1 to 5. It's really used quite universally across different countries, and different societies adopt them quite in a similar manner. To put it simply, grade 1 to 3, the difference is the degree of laceration, the intraparenchymal hematoma, and the subcapsular hematoma. One small addition, small modification to that is if there is large hemoperitoneum, that in a grade 3 trauma, it's slightly upgraded. It's only because it just means that the subcapsular hematoma is so large that it has ruptured and may have stopped at the time of scanning. And grade 4 and 5 basically means a degree of devascularization from segmental to total. A little bit on the embolization technique. So splenic artery is not an end artery, as some of the, sort of first year medical school anatomical sort of diagram may have misled to that concept. In fact, there are three collateral pathways via the spleen, via the omentum, and via the left gastric vessels. And therefore, there are two schools of thought or two categories of interventions. One is proximal intervention, that is to block the major artery just distal to the transverse pancreatic artery. The theory behind that is to reduce the overall perfusion, volume, and pressure to the injured spleen, therefore reduce the rate of the developing pseudoaneurysms and stop, minor bleeds. Whereas the distal embolization is more to target specific truncated or injured vessels. The idea is to stop the bleed. Therefore, a lot of different materials can be used for that sort of end segmental arteries. And this is a key differentiation, which I'll come back to. Unfortunately, the management of different grades of splenic injury is not very well, there's not a lot of evidence around it, apart from case control studies and some retrospect reviews. And here shown are two recent and large volume studies done in Australia and Europe. Until this study comes out, which is published in JAMA Surgery in 2020, it discussed the effect of prophylactic embolization in patients with blunt splenic injury of grade 3+. And here we're going to talk about this in more details. So it's a prospective randomized multi-center study in France between 2014 and 17. Patient selection-wise, they're mainly adults, they are hemodynamically stable, and they present within 2 days of the initial injury. In terms of the grading of the injury, we have splenic, so the grade 3 injury with, at least with large hemoperitoneum, i.e. grade 3+, and or associated lesions that produce a new injury severity score of 15. And we'll come back to that score a bit later. And grade 4 and 5, devascularized splenic injury. And approximately 140 patients were enrolled and randomized into 2 arms. One arm is prophylactic splenic artery embolization. The next one is surveillance and then embolize, i.e. watchful wait sort of approach. So for the prophylactic embolization, there are 2 techniques shown at the bottom of the page. It can be proximal embolization only, or it can be a combined distal and then proximal embolization. And the authors stress that they use the slightly larger coils and avoid microcoils, and definitely not use the firm embolics such as glue and gelatin fragments, etc., to avoid infarction. And we'll come to that, why that's the case. Approximately 60 patients at the primary endpoints in both arms. The primary endpoint, quite interestingly, set by the authors, is 50% of the splenic parenchyma preservation at 1 month. There are several other secondary endpoints, including slightly longer term splenic rescue rate, major complications, etc. So first, we'll look at the demographics. I think suffice to say that between the 2 groups, the baseline characteristics are very well balanced. They are usually young male, employees or student groups, and the injuries most frequently occur in traffic accidents. In studies like this, would involve polytrauma patients who might not be conscious or easy to evaluate. The authors also include a table, which I've not shown here, to include the patients that are non-evaluable clinically. And now we'll come back to the new injury severity score. The way it's calculated in this study is by square the grade of the specific organ, and then you choose the 3 most serious injured organ and add them up. If, for example, a splenic injury is grade 4, the patient already scored 16. And even the minus injury of any other system, for example, chest, 1 point, and neck and head and neck, another point, you will already produce a score of 18. So in this study, the NNS score, the median score for 2 arms is actually 19 and 20. So bear that in mind. I can't find in the paper or the supplementary material to separately describe other injuries that this patient has suffered, particularly those who other organ injuries that may already require intervention with or without a splenic intervention. The primary endpoint, splenic rescue rate. At 1 month, there's no significant difference between the two. The prophylactic arm achieved 98%, minus 1 that went a bit too far and became necrotic. And the other group achieved 93% in the watchful wait, 1 necrosis and 3 splenectomy at 1 month. There's a breakdown of different centers, how they achieve the splenic rescue. As you can see, the overall is very high in the high 90s. And we'll come back to that in the description. And looking at the splenic artery embolization as a technique itself. So for the prophylactic group, everyone would have underwent a technically successful embolization front on. 1 required additional re-embolization at day 5, whereas the watchful wait group has got 19 patients. At 1 month, so slightly delayed, in total only 2 patients for the prophylactic group requires re-intervention, although I was unclear what kind of technique or which vessels they went back into. For the surveillance group, overall, about a third patients required some form of intervention, including 1 patient required 2 embolizations. The overall complications related to the procedure is not very significantly different between the 2 groups. The overall complication, as shown here, looks very high, 45% and 52%. But if I draw your attention to the table on the right, the authors count splenic organ-specific complications such as AV fistula formation or pseudoaneurysm formation as complications, sure, but also hemorrhage that requires transfusion as complications. I think that significantly pushed the number up. And organ-specific complications, the only one that jumps out is pseudoaneurysm, which is significantly higher in the surveillance and then embolization group. Interestingly, none of the groups develop splenic abscesses. And there's no other significant complications specific to the spleen otherwise. The hospital stay is much shorter for the prophylactic group, as you can see. And one might argue that the shorter stay might also reduce the complication, particularly in the COVID roaming world. Predictors for the surveillance and embolization groups, the one that really comes up is grade 4 injury or above. As you can see, 70% actually requires certain form of re-intervention, whereas only 1 in 5 in degree 3 or lower. And actually, no other characteristics have any predictive value. One thing I noticed that in the secondary outcome, the authors wish to talk about immune function assay for the patients who underwent embolization, but they actually have not reported in this particular paper, but all other secondary outcomes are adequately reported. So a quick summary. So the prophylactic group, 100% technical successful early prophylaxis, a prophylactic embolization. 3% require embolization by 1 month, that's re-intervention. 8% minor procedure-related complications, 45 all complications by 1 month. Overall, 98% spleen rescue. The other arm, 12% would develop pseudoaneurysm, as would be predicted by the pathophysiology, I suppose, as with this splenic AV fistula. And 5% would already require splenectomy by day 5. A third would require a form of definitive intervention, and grade 4 and higher injury is the strongest predictor. Again, non-really statistically significant rate of procedure or complication between the two groups, and overall achieve 93% rescue rate. A quick discussion, just draw from the paper and some comments and questions. The author drew to conclusion, rightly, that there is no difference in the splenic rescue rate between the two groups. But as we can see, the complication profile, the event timeline, and surely the patient experience will differ. Overall, second point, overall very high splenic rescue rates compared to historic data, and that's 100% correct. In fact, historic data shows approximately 60 non-operative managed patient would eventually need splenectomy. And this data was from early 2000s. And based on that assumption, the study is probably underpowered because they over-assumed the difference of the two groups. The third point is a choice of 50% splenic mass preservation. What I think is very meaningful, is perhaps more meaningful than splenectomy rate, which splenectomy can happen as a result of over-embolization, I suppose. The study actually did a lot of immune function studies, but they have not published it. It may help us to find a more precise percentage that is a function's spleen. A spleen can still remain function. For example, if it's set at 20%, then the embolization may or can be more aggressive, for example. A fourth point, the selection of hemodynamically stable polytrauma patients. As I earlier alluded to, a lot of these patients coming in a polytrauma setting, and it would be quite good to know whether any of these patients underwent intervention for other organs, or even as a question, whether we still would prophylactically embolize somebody's spleen if they are hemodynamically unstable, for example, from a liver laceration as a coexisting injury. Further points, expert availability in clinical trial context. Sure, I mean, there will always be diagnostic discrepancies, technical variability, and limitations in the real world. Could we possibly achieve this in the real world? I'm not sure. Inpatient reassessment, outpatient follow-up, different pathways definitely require different labor intensity, either for the trauma or surgical team, or even for the prophylactic group. You would front load the pressure onto the IR services. Has there been a medical economic calculation here, and what would the outcome be? And would a patient choice mean anything here, particularly for these kind of patients who are quite severely injured? In reality, I'm not sure what's the percentage of loss to follow up, which I presume is quite high, and would different strategies, which result in different timelines, affect the overall outcome and equity. Just throw out some thoughts and questions out there, but I'm going to hand the floor back to the panelists for more food for thought. Thank you. Right. So, hi, Dr. Kashef. Would you like to comment?
Well, thank you very much for the summary and your presentation. It was very good and very on point, and I particularly like the beginning intro section. Well, actually, I wanted to sort of maybe we could open up the discussion because obviously this is a randomized trial and we don't have many of those in trauma. And the reason for that is because it's just so difficult to randomize during trauma. And there are many factors where I felt are important to consider, which were excluded. And I think it's very difficult to simplify. The reason we don't randomize trauma is because it's very difficult to sort of categorize them and compartmentalize. And I think this trial attempted to do that, which is why the numbers were so small. But I'd be interested to hear both Morgan's and Mo's opinions on it before I, go all extreme on the paper.
I'll come in there. Yeah, thanks, Elika. You actually took the words out of my mouth. First of all, thank you for a very comprehensive run through of that paper. And quite rightly, as Elika pointed out, it's very difficult in trauma to get any really high quality randomized controlled trials. And if you really wanted to look at does prophylactic splenic embolization really work compared to trauma, you'd have to include all the hemodynamically unstable patients as well. But that's never going to happen because you're never going to get ethical approval, or never mind financial approval for that. So straight away, you're dealing with a slightly separate bunch of patients. I'll give you my take on it as a surgeon. And I know in Imperial, we're absolutely spoiled with the interventionists we have, because Elika and Mo and lots of other people will come in and will embolize spleens whenever. And that's not the case around the country or indeed the rest of the Western world. So we're, absolutely spoiled in Imperial. But the way I see it is, from my point of view, surgeon, obviously if your patient's hemodynamically unwell, and I don't like using the word stable, hemodynamically unwell, they get surgery. Because not just because the spleen is bleeding rapidly and the patient may die, but because other things are probably bleeding as well. Then you got the cohort of patients who are hemodynamically well. As far as I'm concerned, if there's an arterial side to it, whether you want to call that an extravasation blush or a pseudoaneurysm or a small AV fistula, then I think embolizing makes intuitive sense. Absolutely does. Because what it does is it improves your chances of successful non-operative management. But the vast majority of splenic bleeding is still venous. But if you see an arterial side to it, by embolizing it, your hemodynamically well patient, it improves your chances of having a successful non-operative outcome. The bulk of the data out there, when you go through it, and it's a bit of a minefield, is does embolization make a difference if you don't have an arterial side to it? And my intuition is it probably doesn't. And this paper kind of agrees with that. But the good news is it's also non-inferior. So there's no right or wrong answer. So if you choose to embolize all your spleens, is that the wrong thing to do? Probably not. If you choose to non-operatively manage all the spleens that do not have an arterial component, is that wrong? Probably not. So in many ways, this paper, like all good research, it probably asks or poses more questions than it actually answers. And just before Elika or Mo come in there, the other thing I'll say is that the grade of splenic injury, while it's useful to talk a common language, and while it's very useful for research, it doesn't really anymore inform us of what to do next, really. And I know there are many institutions that at grade 4 and 5 will all get embolized. And again, I'm not saying that's wrong, but I'm just saying that maybe the outcomes aren't that different to those who we choose to manage non-operatively from the outset, who do not have an arterial component to this splenic injury. And I'd be delighted to hear Elika and Mo's thoughts on that.
I'm really sorry to interject here. So joining us also in the panel is Dr. Sean Dariushnia. Apologies.
Close enough.
Hi, sorry about that. Hello, hi, thank you for joining us. And Dr. Dariushnia is an interventional radiologist practicing in Atlanta and University of Emory. Welcome.
Thank you. Yeah, it's first I want to say it was a great overview of the paper. I would echo what Dr. McMonagle had mentioned previously. This paper definitely opens up more questions than it does answers. From our perspective, we typically follow the EAST guidelines, which is the Eastern Association for Surgical Trauma guidelines, and most in patients with anything greater than a grade 2 splenic laceration, you've bought a angiography, at least an angiography. We haven't really set up protocol for prophylactic embolization. Usually it's only embolized if you see a blush, but this could definitely, with this paper, it could definitely change our practice paradigm in some way. The argument could definitely be made for prophylactically embolizing, just to, from a quality perspective and for affecting length of stay. But the authors did mention, and I think this needs to be further evaluated. You're trading length of stay for the cost of the procedure, so which is not insignificant, at least in the United States.
That's an interesting point, because obviously, as you say, I mean, there is no right or wrong answer in the sense that no one's found a consensus kind of internationally. I think from our perspective, up to grade 3, obviously, I'm very much against just protocolization, because I think you have to look at the patient, and there's always more to it. That you can get just isolated splenic injuries, but there's always more to it. And as Morgan says, things like the degree of trauma, everything else, as well as the spleen, is such a key component of what you do to the patient. And I'm like Morgan, I don't like the word stable or unstable. The patient either needs physiological support or they don't. And I think we've always kind of, up to grade 3, we go towards non-operative, and then we discuss at grade 3. But the sort of the retrospective data is that if there's no blush on the CT, your identification of blush is lower on angio. So the question is, do we just embolize those groups? And I think from my perspective, I do look at the clinical scenario, whether the hematocrit's low, if the patient's about elderly, if there's other traumas, is the capsule intact, is the hilum involved, and sort of we use those factors to go for reduced perfusion pressure. And obviously we do targeted for when there's actual bleeding, and we stop the active bleeding. So our practice obviously is slightly different to yours, but it's interesting to see your aspect. So you would do an angio, but not necessarily the embolization component. Is that correct?
Correct. Yeah. It's basically, and you're right, that with CT, there's a high correlation with bleeding on CT and as well as, since bleeding on angiography. I think their thought is that they want to make sure that we're not missing any potential for visualization of pseudoaneurysms or that may be missed on the phase of the CT. The phase of the CT may not have gotten it, and the angiography is kind of more specific, test
Findings, yeah.
So
busy calls for you, huh?
Yeah. Yes, of course. It's every in the way they're read, there's a lot of variability in the interpretations of these CT graded injuries. Yeah. So yeah, we tend to be pretty busy.
Can I comment on the paper? Can you hear me?
Yeah.
Yes. Yeah, please.
All right. Okay. So I'll take you back slightly to the paper. I think and you did mention that to find a RCT in trauma is not common, and it is quite interesting, and they should be congratulated for this attempt to study the splenic laceration. Now, I must say the setting of the trial, it's obvious that the authors did their best to maximize and standardize the protocol of the procedure and try. So the imaging assessment, the way they mentioned how they acquired the images are quite good. And all the conduct of the trial, it seems fair and was well done. My issue with it is when it starts to analyze the results. Now, one thing in this paper that yes, it is randomized to arms, but the analysis was based on intention to treat. So patients, without really commenting or taking into account the crossover. So patients with the surveillance arm going to embolization and the successful embolization, but the success goes to the surveillance arm because it's intention to treat. That's my interpretation of it. The other thing, and they did not comment. So overall, yes, they achieved quite good results in saving spleens, both arms. But 1/3 of them underwent embolization from the surveillance arm. So this 1/3 is significant. And I was a bit surprised that they did not mention that in the conclusion or or alluded to it in the conclusion. Because if you have 1/3 in the surveillance undergoing sort of emergent embolization, that's not good for surveillance. What, I mean, 26, I think, out of 60, something like that. It's quite high. And the length of stay, and I think our guest from Stays mentioned that length of stay, it is important. And even if it is not, in UK, we run the public health system, but the pressure on beds is massive. So if we manage to discharge patient earlier, 4 days, I think that was the difference, more or less, it's significant. So, and the other thing is the grade 4 and 5, the majority of the reintervention or the crossover was in the grade 4 and 5. I would probably have felt more comfortable if they said that there is a difference, but in the higher grades. And we can't prove it statistically, and we need more studies. That would, to me, that would be a good come out conclusion from this study. But overall, I mean, if we go to our practice, I mean, I can't replicate what Elika is saying and Morgan, because we practice in the same place, and we have sort of same sort of school of thought. Yes, high grade. I personally have, and I think the rest as well, have low threshold to intervene with embolization. I agree with Morgan that if the patient has multiple injuries, I mean, it's not only spleen, we need to look at the overall patient. But I disagree with one minor point. I think if you have another injury, that does not justify you go and deal with the spleen openly, because you cannot do splenography properly and successfully in most of the time. And the idea of saving spleen and stabilize the patient and then patient goes to theater, to me, it's a good thing, because you save spleen, you improve. Yes, we haven't yet improved the immune function of the spleen. And I don't think we will be able to do that for foreseeable future, but I think it is something that is welcome to if we save spleen. Sorry, I'm taking too much.
I know, I agree with you. I think the options of, I think for me, delayed bleeding is the thing I want to prevent, because if someone's unwell and they go to theatre, but if you're going to, you can't swap angiography and embolization in a hemodynamically unsupported patient and just take the spleen out. And I think we've definitely moved away from just, we embolize. I think we've become more selective on our embolizations and our splenectomies, and we've learned the pattern, and especially with the pediatric population, which is an area on its own, you can push the spleen a lot before you have to do anything to it. So I think we're kind of less aggressive than we used to be, say, 10 years ago when we started at the trauma center. But I think, I absolutely think if there's any kind of extra anatomical bleeding or evidence of a ruptured spleen, and the patient's got an isolated injury, there is definitely scope of reducing perfusion pressure. But if there's more than 2 or 3 quadrants of blood and the patient is ongoing support needed and there's going to be other things and the spleen's ruptured, obviously that's a different argument. But I agree that I think if we, what I don't want happening is people moving towards a whole delayed bleeding thing and kind of not embolizing high grades, and then we're going to come back 2 days later and they rupture. And most of these, we used to think 2 weeks was the delayed bleeding, but now we find the first 72 hours is where the data shows the delayed bleeding will happen. And no one knows who gets the delayed pseudoaneurysm and who doesn't. We've looked at grades of injury, we've looked at the ASST, we've looked at the SSI, and there is no indication. And obviously the only thing, the pattern we've found is the higher the severity of index of the injury severity, the higher the risk of embolization. But that's kind of hand in hand anyway. So so we haven't yet found out which patients bleed or not. Even though the blood supply of the spleen is much simpler than the blood supply of the liver, we still haven't figured out the pattern. And all this literature supports the fact that we don't know which ones will bleed and which ones won't. And just the grade of injury is not enough to predict that.
Yeah, I'll come in there. I agree with everything Elika said there. I suppose one way to try and answer some of those questions would be just to super select all those patients who did have an arterial complication who were embolized and look at the rates of rebleeding and splenectomy later on, because there will be a group of patients who will still continue to bleed from the venous side, but you would hope that that number is mitigated for by taking care of the inflow. One thing just to take Mo up on, well, not take him up on, but you mentioned about the length of stay. I think that is very relevant because it was quite a significant difference between what was it, 13 days and 9 days between those who were just surveyed versus those who had an intervention. And I would like to see a super selective study done, maybe from the same data, looking at what was the length of stay for those patients who went to theatre and had their spleens out. And in particular, those who had isolated splenic injury, no other significant intra-abdominal injuries, what was their length of stay? Because if it's the same or worse than those who had an intervention, then we know intervention is clearly a good thing to do. And as Mo said, if you can preserve the spleen and then operate, that may be a good thing as well if you had a hybrid type operating suite. The other thing I'll put out to the panel is, who are radiologists or interventionists, is maybe this paper will inform future practice from the point of view that if you are going to intervene for the traumatized spleen, you don't have to do it at 2 or 3 in the morning. It can wait, because if you look at the reintervention rate, they were similar between the two arms, but they were also delayed. So maybe that's a good thing, that you don't have to come in at 2 in the morning and embolize the spleen. You can actually do it at 7 or 8 in the morning.
If I can sleep after the phone call.
Well, exactly. I mean, and that is important too. You know, that maybe you don't have to fly the plane in the storm at 2 in the morning. You can wait until the morning.
That's a very good point, actually. I agree. There's definitely a psychological component to it, for sure.
So just on that, actually, it's a very interesting one. So Dr. Dariushnia, so if you were to do the angio, do you do that quite soon after the CT, or do you wait?
It's variable. We use clinical status more. We don't treat the CT. If the patient needs urgent angiography, they've given a bolus of fluids and they responded, and then they notice a drop in blood pressure. Our threshold is pretty low to come in and just do the procedure, get it over with. So we try to keep our trauma surgeons happy.
Could I ask Dr. Dariushnia, I know some of the trauma guys at Emory, what is your current practice for splenic imaging follow-up?
Yeah,
for those who've had an intervention and those who have not.
Yeah, usually 1 week is kind of the first imaging data point when we get anywhere from 5 days to 1 week is and then before they're discharged, because it's so hard to follow up sometimes these patients, the trauma.
So you do re-CT your intervention, splenic interventions. Do you re-CT the patients who have not had a splenic intervention?
Yes, we do. Those are typically at the least before they get discharged home. Before they get discharged home.
And what are you looking for if they're well?
Again, looking for delayed pseudoaneurysm formation.
And if I may push you, and I'm asking this respectfully, if you do see a small pseudoaneurysm, the natural history of it is it may just sit there benignly. I'm being a devil's advocate deliberately. What are your thoughts on that? And Elika and Mo would be interested in their thoughts too.
Yeah, we tend to be pretty aggressive. So if we see even a small pseudoaneurysm, it's at least bought the patient an angiography. Even delayed, a week or 2 weeks out. Yeah.
We have got that same one. I mean, Morgan's aware of this. We do the follow-up. We do a limited, like a triple phase, depending on the injury, obviously, but we do like a limited triple phase spleen at 72 hours. And then we do one at 6 weeks afterwards. And we've actually picked up 2 pseudoaneurysms at 6 weeks, completely benign. But it's one of those scenarios that when you see it, you can't ignore and you just think, why are we scanning these patients? But then it's very tough because I think most of what we've developed is based on practice rather than an actual science, because we don't have it, and it's our experience that's driving our practices, I find, which is obviously your practice is different to ours, but it's both of them are working and we have good outcomes. So it's interesting that even though we have different practices, outcomes are working, which kind of goes to my previous point that we're still kind of not using the science of it because we don't have the data for it.
Right.
Yeah, that pseudoaneurysm is a special problem, not a special, but it's a problem for me as well, because it's like the visceral aneurysms. The evidence for it is not level 1.
Yeah.
And the problem with this, in the context of splenic injury, that if the aneurysm is 2 centimeters or 3, it's easy because it needs to be done. But the problem if the aneurysm is like 5 millimeter, or if it is a centimeter and it's in the middle of the parenchyma, what are you going to do with it? And the patient's stable is day 5. If you leave it, it's obvious there will be more and more imaging and might delay discharge. And I don't think anyone has a definitive answer. I usually follow my hunch feeling. So if the aneurysm is large, that's not a question. That's easy. But if it is a centimeter and below and near the laceration, near the capsule, and I don't feel that it is sort of protected, it's a very anecdotal thing. Then I go and embolize. And the interesting thing, and that happened to me several times, when I go and do angiogram, I don't see it. But it is done, it is seen in the CT, done a couple of hours before.
Yeah, exactly the same scenario for us as well. We've had this a couple of times on our days, and it's just the same. It's just very frustrating. And then you're stuck because you visualize something, you can't visualize it again. Do you then embolize or not? So it's an interesting point, because I'd be interested to know what Sean thinks, because I've seen exactly the same scenario.
Yeah. In the past, I've been pretty, if I don't see a bleed on angiography, I have not embolized. But I think our practice has somewhat changed over the last couple of years. Just for the risk of, and I don't know, and I don't want to admit this, but I think in the United States, we often practice under the medical legal umbrella, and I'm not saying that's good, and it doesn't often follow the data, but if you see something on CT, you've got a small pseudoaneurysm, and you don't see it on angiography, which is a conundrum. The patient's about ready to be discharged. Do you just leave it alone? Do you embolize it? I don't know. I guess, especially in our population, because a lot of our population will not be followed up again ever. So I think we're starting to, our practice is just starting to veering more towards embolizing prophylactically, even if you don't see it on the angiography.
I have a question coming from the the paper made me think about it. They use what they call it stiff coil, something they use a word describing the 035 coils. And they said we haven't used microcoils because to reduce the risk of infarction. What Elika and Sean think about this?
I think the thought was that you put in 018 microcoils, the risk of distal embolization is greater. Compared to 035 coils, which can be a little bit, more
proximal.
I don't know. That's how I interpreted it. I don't know.
I think with the technology available with the 035s as well, you can get, and you can get this, the more flexible coils as well. So I think there is availability of doing what you feel is right, not one feels is right. So I think there are definitely more, I'm not a massive fan of them, but definitely more flexible coils available that are 035 and 038. And I'm not a fan of plugs generally. I like to use coils because I just like the motion of feeling more in control of them. But I have done combination of coils, plugs on their own, micro coils. It all depends on the anatomy and the access. How far can I get in? I think it's multifactorial rather than a simple, this is what you do.
And just for I know it's outside the paper, but just the benefit of juniors, do you use liquid or particles or slurry? Why is that?
I don't like to use liquid slurry. I have used when there's active bleeding, and especially when a patient comes on the table and they become quite unwell and they need sudden increase in input. You have to sort of block and plug the area. So you would do gel foam slurry. But I think because of the collaterals around it, from the short gastric, from the pancreas, omentum, and going down to the colon, I generally like to have control of where I've embolized. So where I embolize, I want it to be there. So I personally don't feel, and I think the literature says, use of particles is ill-advised, but liquids, I have seen people use it on literature, but I personally don't feel it's appropriate.
Yeah.
I'll use particles and liquids for hypersplenism, for partial infarction of the spleen.
So it's interesting because I think that works for that one, because that's an abnormal area where the vascular is developed with it, whereas these guys have got supposedly normal anatomy, so the vasculature hasn't developed. That's how I think about it. It's the same thing with livers and tumors, and we do use particles in the liver for trauma, but not in the first instance. It's more to do with like the pathology of the whole process, whereas the pathology here is just the transected artery. That's how or liver or spleen. That's how I kind of process it in my head.
And I'm always aware of the pancreas. It is nearby, so I know it is very rare, but when it happens, pancreatitis, it's a horrible complication. And particles, in theory, could cause that. I've seen it once. And when it happens, it's a very regrettable complication.
Would you find that the practice is, as you say, you've had one incident, and for me, it's a psychological issue. I don't have time.
I've seen it. It's not with me, but I've seen it.
Exactly. No, but exactly. But I think for me, it's what my practice has done. I've got no scientific data to say don't use particles. It's just my logic of the anatomy and everything, and it's just one of those things where the data just isn't out there for us to start randomizing to liquid and coil. I thought was a question. Please complete the feedback survey to receive the certificate of attendance, everybody.
So, Morgan, can I ask you a question?
Sure.
If we went to take this paper and move forward with another sort of research, how would you do it, or what would you do?
I think you'd have to specifically look at those patients who had a contrast flush and super select those out and compare them to the hemodynamically unwell patient who went straight to theatre. I think that would be one nice group to look at. The other unanswered questions are the patients who don't have a contrast bush, who just have a venous injury to the spleen, what's the natural history? Because again, a lot of what we base our practices on, especially as surgeons, is old data. And traditionally, we thought the non-operative success rate of splenic preservation is only about 65%. What we do know now is that's retrospective data, of course, that tells you what was done rather than what should have been done. We now know the spleen is far more robust than that in the hemodynamically well patient. The other question is about the spleen itself and the infarction, and whether you use coils or some sort of embolization chemical. We don't really know what percentage of spleen we need to keep immune function, especially in the adult population, because most of these adults will live a normal life without their spleens anyway. And the old-fashioned risk of overwhelming post-splenectomy infection is almost unheard of in adults, almost unheard of. So you're going to need a huge population of patients to try and answer the questions that we all argue about. The one final question I would ask is, I know Elika has asked this before, is there room to have specifically trauma, subspecialized interventionists as a training pathway? That might be relevant to a lot of our audience tonight. And I think there probably is.
Oh yeah, for sure. I mean, look at how much we've spent just talking about one component of one organ. I think it's a huge area, and it's somewhere that academically we're so weak in, both in surgery and in IR and in radiology. Radiology less so, because I think radiologists are very good at making fancy papers out of everything, but IR for sure. And I think what you mentioned about splenic infarction is actually, going back to that point, is very important, because I think we used to go for end targets, and as time's gone by, the literature has shifted towards the whole proximal embolization to just give enough perfusion pressure drop, but not infarction. And there's no real scientific way of actually measuring the splenic function. Or does it take a hit? Does it have its own little local embolization syndrome? We don't know. But what we do know is obviously scanning them at 6 weeks, it allows us to assess the vasculature, which is one of the reasons we bring them back at 6 weeks. And we're very similar to you, Sean, where our stabbings don't tend to come back to us. So it's just that blunt trauma that come back.
Just to follow on from that and what Mo asked, I would like to see a proper longitudinal study following the small pseudoaneurysms.
Yes.
See what the natural history is.
Yeah.
And I agree that it might take some guts to do it, but I think we don't know what the natural history is. And I would suspect a small pseudoaneurysm, I would suspect most of them go away.
Yeah. Even in this paper, the few pseudoaneurysms, they were equal I think at 1 month. There was significantly difference between the two arms, but then they equalized.
And we have one question here, I think. Do you want to read it out, Dr.
Yeah, we've got one question from the audience. So how do you manage patients you decide not to coil if they are most likely to bleed within the first 72 hours? Do you observe for 72 hours and then discharge if they are stable? Or do you have
we say a special prayer to the trauma gods and ask for the bleeding to stop. And it always works.
I'll give you my take on it. So if you don't intervene, that's the question, yeah? Because they haven't got arterial complication in their spleen, so it's parenchymal venous bleeding. As a general rule of thumb, you take the grade of spleen. I know I said already I don't really believe grades anymore. Great for research, not great for informing you. Grade of spleen, let's say it's a grade 3. That patient scores themselves 3 shifts in a high dependency critical care unit, being very closely monitored, and 3 days in the hospital. It's not great science, and it comes from the Children's Hospital of Philadelphia. It's based on pediatric patients who we know tend to do better anyway with spleens, but it's the best data we have out there.
Right, so it tends to be more based just on the patient and whatever.
Clinically, except I'll throw one more caveat in, even if they remain hemodynamically rock solid, someone who's needing continuous boluses of blood, so they're bleeding slowly, that in itself can be an indication to take out the spleen.
Yeah, okay, great.
Or embolize the spleen.
Or embolize the spleen.
Read the room, Morgan, read the room.
play to the audience, right?
Exactly. No, but I know I was going to exactly what you said it as I was about to say it and cut in to say that for us, the drop in hematocrit and an ongoing support needed with no other cause, it's really important that we know there's nothing else going on, because obviously then you have to think about the whole thing. But if it's just a splenic injury and you keep dropping your hemoglobin, just little drop, it doesn't have to drop to a significant level. That is an indication for intervention, not just splenectomy. That's not going to
go. One quick question from me. For post-embolization patients, when do you decide to go for the asplenia or splenectomy prophylaxis, antibiotics and vaccine? When do you choose to give the patients that long-term
embolization?
Yes, following embolization.
We don't go for long-term, but we treat them as for the immediate period. They get the little cocktail that they would get if you had a splenectomy, but we don't go for long-term antibiotics.
The best time to give the vaccines is when the spleen is in situ, if you can. So even if you're going to manage it non-operatively, my practice is to give it while the spleen is still there, even if it ends up coming out a couple of days later. So if you embolize, by definition, you don't need it because the spleen is there. But let's say the embolization fails, you're better off giving them now. It's a benign thing to do while the spleen is in situ. In the UK, the guidelines are that they should be on lifelong antibiotics. The CDC in the United States, unless I'm incorrect, and Sean can correct me if he wishes, does not recommend lifelong antibiotics. I don't believe lifelong antibiotics work in adults because of the issue with compliance. They don't take them. You just don't take them.
They just develop resistance. That's all.
Yeah, so my general advice is to a patient who's lost their spleen, keep their vaccines up to date. And a bit like a patient with an artificial heart valve, if they become unwell at any stage, they may want to go on to a short course of antibiotics. Maybe. I have no evidence one way or the other to say it makes a difference for longevity.
Great, thank you. Any other comments? Any questions from the audience? I think there's no more questions being asked.
I just had a question, mainly about just from obviously work in a public healthcare system. Do we know what it costs to take someone to do a prophylactic splenic artery embolism? Because obviously, if you've got these 26 patients that in the surveillance that go on to need splenic artery embolism, but embolization, but if we've not got any money and you need to balance it with a cost benefit, do we know how much it does cost to take these patients to the interventional suite?
I can tell you in the United States, it runs anywhere from $8,000 to $10,000. So it's not cheap.
Mm.
But then you balance that with an ICU bed.
Yeah.
That costs several $1,000s per night. And
that they might need if they then go on to develop secondary delayed bleeding. Yeah.
But this is coming from the United States, where our cost of healthcare is just ridiculous, and it's, you guys do it better, I think, as far as economy and.
It still costs money. It's just paid in a different way.
Well, I mean, the calculation in NHS is extremely difficult, and most of the time it's virtual accountancy.
Monopoly money.
Yeah, it is cost of coils. That's the maximum, because the catheters and wires and contrasts are all cheap. Interventional radiologists are the cheapest thing in that equation. It is the coils. Use 4 or 5 coils. Each coil is around 250, 200. So you can calculate that.
Mm. I mean, there are costings being done all the time about it. I don't have the numbers. We try to not worry the talent with the costs, so we don't know the exact figures, but
so costing for fibroid embolization is around £5,000. So this is less. So you can make comparison.
And I think fibroids have a proven cost effectiveness, isn't it, for the number of bed stays, recovery, return to work, and for the whole economy rather than just the hospital. So it's multifactorial. Some suspect the trauma would be similar, but obviously it's a lot more complicated. So I don't think anyone got a true figure for it. A project for you juniors, if anyone's interested, it's a big project, but I think it's an interesting one to look into.
Great, thank you.
Great, thank you very much. I think we had a wonderful discussion there tonight. Thank you for all the audience participating in this session as well. And particularly thank you for the panelists who gave us precious time to our discussion. Thank you very much. I think we should conclude the session here and hope you have a very good night.
Thank you very much.
Thank you very much.
Thank you.
Bye.
Bye-bye.
Ask everybody to fill in the feedback form. The link is in the chat. Thank you.